Hello and welcome to Chapter 11 in Computers and Healthcare. We're going to be talking about Health Information Exchange. All right, so if you want to follow along in the book, you can start with me on page 181, and we're going to define HIE, or Health Information Exchange. So currently, the federal government is encouraging statewide HIE, or Health Information Exchange, to support the nationwide Health Information Network, referred to as eHealth Exchange. HIE is defined as the formal, agreed-upon process for the seamless exchange of health information electronically between providers and others with the same level of interoperability, according to nationally recognized standards. All right, so moving over to 182. HIE requires a shift in mindset for healthcare professionals from treating individuals with a specific practice or facility to understand how healthcare organizations impact the health of the entire community in which they practice. HIE can improve patient outcomes by reducing medical errors and increasing the efficiency of care by decreasing unnecessary tests and services because the health information is readily available for all providers. These steps, in turn, support healthy, productive citizens. HIE encourages patients to become active participants in their health care and well-being by offering information and education about health conditions, managing chronic diseases, working with diet and exercise tracking apps, and decreasing completion of repetitive paperwork needed by providers. HIE works to bolster community health by coordinating with public health officials by identifying disease trends, implementation of immunization programs, and developing health education programs for at-risk populations. These new cultural norms must permeate through every personnel layer and work process in the healthcare organization. The traditional silos of information or territories exclusive to one aspect of care must be broken down to allow free exchange of information and ideas and foster better coordination of healthcare services for the duration of the patient's life. Value-based healthcare is an evolving concept focused on three areas: better care for the individual, better health for the community, and lower cost of healthcare through improvement of services and delivery methods. All right, so let's talk about interoperability. And the way I've always explained interoperability is think about a telephone. It doesn't matter if it is a landline. It doesn't matter if it's an iPhone. It doesn't matter if it's a Samsung. It doesn't matter if it's an old Motorola Razr or even an older flip phone. It doesn't matter what kind of phone it is or who your carrier is. I can call you from any kind of phone. So that's interoperability. Those phone companies work together. Doesn't matter what type of phone you have, you can communicate with other people through those telephones. So think about interoperability in that aspect. You've got different phone carriers, you've got different phone manufacturers, but it doesn't matter what kind of phone it is, what service you have, whether it's a landline, you can still call and speak to someone else with a different kind of phone than you or a different carrier than you. So on page 183, we start at interoperability and health information exchange. The exchange of health information between entities is possible only if interoperability is in place. Interoperability is the capability of different information systems and software applications to communicate and exchange data. E-prescribing, in which pharmacies receive electronic prescriptions from hospitals, physician practices, and health departments, is an example of interoperability. It is likely that each of these healthcare organizations have a different electronic health record or information system. Nonetheless, the pharmacy must be able to securely receive a verified prescription from a licensed provider and accurately provide the correct medication and dosage for the specified patient. Another example is a primary care provider referring one of her patients to a specialty provider, such as an oncologist or cardiologist. The PCP would electronically send over a secure network all pertinent medical and health information of a patient to the specialist for the specialist to have all the background health information to develop a tailored and comprehensive care plan. Again, each of these practitioners would have different EHRs, but these systems must be able to communicate effectively to benefit the patient. Now let's talk about the different types of interoperability. Dropping to the bottom of 183. Healthcare organizations that are owned by corporations typically have similar systems, but this is not necessarily the case with independent providers. 4 types of interoperability can facilitate a successful exchange of health information. So our first one is technical interoperability. This is based on the hardware and equipment connectivity used in the exchange, and this type of interoperability allows any computer or device to exchange data with another computer or device without corrupting the data or creating errors. Then we have syntactic. Message format standards identify how the data should be formatted or structured to allow the exchange. Interface software, which is programming where one application or entity is told how the other application or entity formats its data so that the receiving entity can appropriately convert the data it receives for processing. So, interface software must be employed for compatibility to enable the exchange. These interoperability standards are not specific to healthcare as they're applied to any electronic transmission between 2 entities. And then we have semantic. This process involves the use of standardized terminologies, such as SNOMED CT that we talked about in health records, to provide clarity, consistency, and appropriate meaning in the HIE. This area of HIE is still undergoing development. And then our last is process interoperability. This is the most difficult of all types of interoperability. Our process refers to the degree of which the integrity of workflow can be maintained between systems and includes maintaining and conveying information such as user roles, data protection, and system service quality between systems. An example of this would be the patient authorization for release of information, which varies by state. Healthcare organizations requesting protected health information across state lines or with other healthcare organizations that have less reputable security and access standards impede the exchange of data. So that one's going to be the most difficult of all types is your process. Moving to 184. The Office of National Coordinator for Health Information Technology, called ONC, is the principal federal entity charged with the coordination of nationwide efforts to implement and use the most advanced HIT and the electronic exchange of health information, and in doing so, establishing interoperability among all health information systems. The ONC was established in 2004 as a result of an executive order by President George W. Bush and is a permanent agency within the Department of Health and Human Services. The ONC was the first federal agency empowered to coordinate and modernize the use of HIT and infrastructure to seamlessly and securely transmit electronic health data to improve patient care and administrative functions. In 2007, the American Recovery and Reinvestment Act, also called ARRA, was enacted to stimulate the U.S. economy during a recession. A significant portion of ARRA was dedicated to expanding the use of HIT to improve the business efficiency and effectiveness of healthcare organizations while increasing patient safety and positive health outcomes. This part of ARRA legislation is the Health Information Technology for Economic and Clinical Health Act, or the HITECH Act, which dedicated more than $19 billion to developing HIT, implementing workforce education and training, certifying EHR products, establishing standards and vocabularies, and driving electronic security and privacy regulations into the 21st century. The HITECH Act was the foundational legislation for the development, adoption, promotion, and use of electronic and computerized applications to create an interoperable health information exchange system. The HITECH Act added new regulations and requirements, toughening enforcement and increasing penalties for security breaches and privacy violations. Fortifying privacy and security standards in HIE help foster more connectivity and communications, and therefore interoperability between systems. It also mandated the establishment and strengthening of transmission standards and protocols to help establish interoperability among U.S. health information systems. The HITECH Act emphasizes use of real-time health information and current emerging technology at the time health services are administered to help providers make better decisions for the benefit of the patient and society. All right, so we're going to move over to 186. Now you can look at the shared nationwide interoperability roadmap. It's kind of hard to see in that book. You may be able to blow it up in your ebook, but it's on 185 in figure 11.2. All right, so moving over to the history of the Health Information Exchange on 186. The HIE concept has evolved over the last several decades from a myriad of attempts at transitioning data from one healthcare organization to another. However, without oversight and coordination from one designated governing body, previous attempts were piecemeal at best. Over these decades, there have also been technical advances that could hardly have been imagined at the inception of HIE. HIE is typically conducted through an intermediary called an HIO. A health information organization is typically a public-private partnership organization that oversees, governs, and facilitates the transmission of health data between different types of healthcare organizations that have various EHR systems according to nationally recognized standards. Many HIOs started as a local health information organization, or an LHIO. I think they may call that LEO because the next acronym, the RHIO, is called RIO. So we're going to go with LEO and RIO. Or regional health information organizations. The Health Information Management Systems Society, HIMSS, defines RIOs as a group of organizations with a business stake in improving the quality, safety, and efficiency of healthcare delivery that comes together to exchange information for these purposes. The terms RIO and Health Information Exchange, or HIE, are often used interchangeably. In a small-scale version of a LEO is a small-scale version of a RIO. LEOs and RIOs are groups of healthcare organizations in specific geographic areas that share electronic health information according to accepted standards. HIOs help the healthcare organizations and providers by delivering the services of patient identification functionality, identity management and security services, and data exchange management. The Sequoia Project, eHealth Exchange, originally known as Healthway, is a group of federal agencies and non-federal organizations that came together under a common mission and purpose to improve patient care, streamline disability benefit claims, and improve public health and reporting through secure, trusted, and interoperable health information exchange. The Sequoia Project is a private sector organization supplying and managing the data stewardship for the nationwide network. Currently, it provides exchange services in all 50 states for more than 1 million patients, which is going to include 65% of U.S. hospitals, 50,000 medical groups, 8,300 pharmacies, and the Department of Defense, Centers for Medicare and Medicaid, Veterans Administration, and the Social Security Administration. Organizations taking part in the Sequoia Project mutually to agree to support a common set of standards and specifications that enable the establishment of a secure, trusted, and interoperable connection among all participating exchange organizations for the standardized flow of information. All right, so let's talk about benefits and barriers. The way this is laid out, I may read through some of these. I'm not going to read through all of these. But in 2000, the Institute of Medicine, later renamed National Academy of Medicine, identified a conservative estimate of 98,000 people who die annually due to the lack of quality in healthcare, including incorrect medications, untimely or incomplete test results, lack of timely access to health information that could influence healthcare decision-making, and lack of continuity of care in all realms of medicine and healthcare. So dropping down, implementing and using current HIT and HIE has many benefits for healthcare entities, providers, patients, and society. So a couple of these, I'm not going to read every one of them. The ability to improve quality of care by increasing the amount of patient-specific data available and decreasing the time it takes to make treatment decisions. Use of clinical decision support software by healthcare providers to assist with more comprehensive and effective care. The increased use of mobile technology such as cell phones, tablets, laptops that can communicate anywhere and anytime. Flipping over to 188, increased and improved effectiveness and efficiency of healthcare treatments and business operations. And then the last one provides basic level of interoperability among EHRs. And because patients are the priority, their involvement, treatment, and successful outcomes must be evaluated to determine best practices to improve patient care. HIT and HIE benefits for the patients include patient safety, automatic appointment and health reminders such as follow-up instructions, patient education information, and medication prescriptions sent directly to the patient's pharmacy, equity of treatment and services with improved health outcomes leading to a reduction of health disparities. Emergency and urgent care personnel can quickly determine the patient's medications, allergies, and other significant medical history to aid in diagnosing current episode of care. And more engaged patient education and patient involvement in the decisions that affect their health. And again, I didn't read all of those, but you can read those in the text. All right, next section, the benefits to society. Equity of treatment and services with improved health outcomes leading to a reduction of health disparities, which that was one of our same ones for the patient itself. Decreased response time for disaster response. Many population public health issues have links to homeland security, such as newly emerging diseases such as Ebola and bioterrorism attacks. Public health surveillance of outbreaks or epidemics of large-scale foodborne illnesses, pandemics of mutated influenza, and the Zika virus spread. And then alerts can be sent to appropriate government and health officials to speed response and mitigation efforts. And this is particularly helpful when outbreaks or epidemics cross state lines. And then we have barriers at the bottom of 188. So, however, along with the good comes the bad. Implementing computerization for a large portion of the healthcare industry creates many changes and problems. So some of our barriers, finance, it's expensive. You've gonna have increased cost of hardware and software. You're gonna have to train your people, and the infrastructure is just expensive. Lack of complete operational and interoperability standards and vocabularies, and inadequate computer interfaces across all vendors and organizations. Then healthcare information ownership between patient and providers. Patient identification and matching capabilities and protocols along the entire continuum of care. Competition and propriety issues between healthcare organizations. And then many rural hospitals lack financial stability and strength to provide new hardware, software, up-to-date IT personnel, and regional geographic infrastructure for reliable transmission of data. The ONC has developed an infographic, which is shown in Figure 11.3, on how HIT can improve the state of healthcare in the United States. And you may be able to see that better on the computer screen as well. All right, moving over to 190, we're going to start with meaningful use. Meaningful use is a regulation that was issued by the Centers for Medicare and Medicaid on July 28, 2010, outlining an incentive program for eligible professionals, or EPs, eligible hospitals, and critical access hospitals participating in Medicare and Medicaid programs that adopt and successfully demonstrate meaningful use of certified EHR technology. The EHR product in question must meet HIT and HIE criteria and standards for functionality and interoperability in order to be certified by the ONC or its designee. AURA and HITECH the HITECH Act specified 3 components for meaningful use, all requiring the use of a certified EHR technology. First, it must be used in a meaningful way, such as e-prescribing and computerized provider order entry. Second, the exchange of health information must be used to improve quality of health care. 3. EHR must be used to submit clinical quality measures, or your CQMs, and other specified measures indicated by the ONC and Department of Health and Human Services. Since 2004, when HIT became a major focus of healthcare delivery, most recent health legislation has addressed many of the negative issues that have been identified in the U.S. healthcare system, such as patient safety, healthcare outcomes, and health disparities. In order to tackle these negative issues, specific guidelines, standards, and level of treatment and patient care must be followed. Using CQMs is one of the ways to evaluate the delivery of care and patient outcomes. CQMs are criteria and tools to measure or quantify healthcare processes, outcomes, patient perceptions, and organizational structure and systems that relate to one or more of the quality goals for healthcare: effective, safe, efficient, patient-centered, equitable, and timely. The CQMs were specifically designed to use HIT effectively to combat negative issues. Meaningful use emphasizes population health reporting. Population health is the same thing as public health. Now, our population health reporting is the aggregate data on immunizations, communicable diseases, and other health events and CQMs that the healthcare entities, providers, and public health agencies are required to report, and is a standard function in EHRs. Population health, or public health, focuses on preventing, diagnosing, and treating an entire group of people rather than one person at a time. Research on the state of health outcome disparities between genders, race, and socioeconomic status that exist within the United States has helped to identify priority populations where much of the work needs to be implemented to alleviate and eventually eliminate these inequities. Data collection of health outcomes and treatment patterns is used to identify specific disparities, and the subsequent epidemiological information is used to support evidence-based action plans for HIT and EHR adoption to improve the healthcare delivery and help reduce health disparities. A health disparity occurs when there are unequal differences in health access, status, or outcome based upon the factors such as gender, race, socioeconomic status, sexual identity orientation, disability, and geography. After this phase, language barriers and health literacy can be addressed, and more effective and efficient communication can be employed to help educate specific populations about their health status. CMS has given priority to research and development of action plans that address health disparities in the following populations: racial and ethnic minorities, immigrants, those who have limited English proficiency, individuals with low health literacy, socioeconomically disadvantaged, disabled and those with special needs, older adults, rural residents, children and adolescents, and then the LGBT community. All right, moving over to page 193, we're going to talk about the different models of HIE architecture. So HIE architecture refers to the configuration, structure, and relationships of hardware in an information system. There are 3 types of HIE architecture that are most commonly used in the United States. First, we have our consolidated method. It's also called the centralized model. This model of HIE was typical of the early years of HIEs. Many independent healthcare organizations connected with the HIE, and aggregate data was stored and shared within a central repository managed by the HIE. The centralized data has a master patient index or a record locator service, an RLS. A RLS indicates where the patient's information is detected within the participating healthcare organization's based on patient identity information and record data type, with robust access and security controls. Each healthcare organization can access the appropriate information. Advantages to the consolidated model include consistency of the data available and rapid response to requests. Duplication of data that is not completely up to date, and cost for supporting software are some of the disadvantages to this model. Then you have your federated or your decentralized model. This occurs where there is no centralized database of patient information. The federated model is more common than the consolidated model because it works much like the internet. Each healthcare organization is responsible for maintaining its own patients' health records and is required to have the appropriate access and transmission safeguards operational. Each healthcare organization is responsible for vetting user access. Vetting is the process of critically appraising the abilities of an organization or person to determine if they meet the stated criteria. For example, a healthcare organization establishes criteria for authorized access to the HCO's health information. The HCO uses the criteria to determine which external entities have authorized access to the HCO's health information. The external entities are vetted for their authority and security mechanisms to access the health information. The federated model has several key benefits, including the lack of data ownership. Because each healthcare organization maintains its own data, the available data are always current, and this HIE has the capability to integrate with many EHR systems, providing redundancy or the use of additional or backup systems. This is particularly important in the case of disasters when a healthcare organization could be damaged or completely shut down. Disadvantages include data availability problems due to technical issues of a specific healthcare organization, and data may not always be available or complete because the patient may have data distributed across many of the healthcare organizations involved. Then our last model is the hybrid model. It combines the advantages of centralized and decentralized models. It has a record locator system, and some data are stored in a central repository while the remainder stays with the other healthcare organizations within the HIE. The hybrid model also has a patient portal to itself and not to a specific healthcare organization. Now we have different methods of HIE. There are 3 methods in which health information is exchanged between appropriate healthcare entities or providers. We have direct exchange, query-based exchange, and consumer-mediated exchange. Direct exchange is frequently referred to as push exchange because it pushes authorized and secure information from one healthcare organization to another. For example, if a patient is being transferred from one hospital to another, the patient's health information would be pushed to the receiving hospital in order to provide the background health information to help the transition of continued care. As part of Stage 1 meaningful use requirements for EHRs, the DIRECT project was initiated in 2010. The DIRECT project is important for the secure messaging and transmission of laboratory results, summary care records, referrals, public health reporting, and conveying quality measures. DIRECT project is a standards-based exchange platform to provide a secure, straightforward, scalable method to transmit encrypted information to collaborating providers. Direct messaging exchange acts like a regular email, but with the added Health Insurance Portability and Accountability Act security mechanisms for protection of both the sender and recipient with direct addresses. Direct Trust, which oversees the DIRECT project, is a federally recognized nonprofit policy and governance body that makes it possible for direct exchange to operate smoothly and reliably, giving direct users a much-needed confidence in their exchange partners' privacy and security practices. Then we're moving on to our query-based exchange. This is a find and seek request for information that is sent through the HIO to find any available health information on a specified individual. It is the opposite of the push exchange. So seek It is the opposite of the push exchange, so it is thought of as a pull exchange. This type of exchange is typically used in urgent and emergency care to seek information that would be relevant for the encounter at hand. Then we have our consumer-mediated exchange. This is a type of HIE that is controlled by patients who want to control the use and access of their health information. According to the ONC, consumer-mediated exchange provides patients with access to their health information, allowing them to manage their health care online in a similar fashion to how they might manage their finances through online banking. When in control of their own health information, patients can actively participate in their care coordination by, first, providing other providers with their health information, identifying and correcting wrong or missing health information, identifying and correcting incorrect billing information, and tracking and monitoring their own health. While some HIT professionals feel that consumer-mediated exchanges would improve health information privacy and cooperation among healthcare organizations, others feel that the complexity and volume of data would overwhelm consumers who would not be able to effectively and efficiently manage and control their information. All right, next section over on 195, we're going to talk about patient identification. Making sure that the correct patient is identified within the HIE is one of the major issues. In a large or densely populated geographic area, there could be hundreds of individuals with common names, such as John Smith. Many methods have been used to address this issue, from smart cards with magnetic chips or strips with identifying information, to advanced computer algorithms, to biometrics using fingerprints, facial recognition, or retinal scans. No one method has been found to be completely correct in its matching capabilities. To make matters worse, all this additional technology is expensive, meaning that many healthcare organizations cannot afford to implement these methods. Identity matching, which is also known as patient matching, is the process in which the healthcare or the HIO identifies the right person within the database to exchange information between healthcare organizations. The process examines different demographic elements from different health information technology systems to determine if they refer to the same patient. From an interoperability perspective, the ability to complete patient matching efficiently, accurately, and at scale has long been identified as a key element of the nation's health IT infrastructure. Patient matching is almost universally needed to enable the interoperability of health data for all kinds of purposes. Patient matching also requires careful consideration with respect to its effect on patient safety and administrative cost. Owing to privacy concerns, Congress has banned the Department of Health and Human Services from trying to develop and implement a national unique patient identifier. However, because of the progression of EHR systems and the issues with patient identification and matching, Congress is now considering allowing the Department of Health and Human Services to lend technical assistance and to evaluate the current state of patient identification management. In the meantime, HIOs must establish other methods for identity matching. The sophistication of algorithms depends upon the type and amount of data needed to solve the query. So basic algorithms compare selected data elements such as name, date of birth, and gender, and these are the simplest techniques for matching records. Intermediate algorithms use more advanced techniques to compare and match records by assigning subjective weights to demographic elements for use in a scoring system to determine the probability of matching patient records. And advanced algorithms contain the most sophisticated set of tools for matching records and rely on mathematical theory and statistical models to determine the likelihood of a match. Identity management is different from identity matching. Identity management ensures that the individual who has been identified is who they say they are, that they have the authority to do what they want to do, and that their actions are tracked. Traditionally, identity management was performed as a part of the patient registration or in health information management when the paper health records or master patient index were reconciled. Individual healthcare organizations develop processes for identity management that are best suited to their needs. For example, at the time of registration, most healthcare organizations require the patient to provide a driver's license or a state-issued identity card, his insurance card, an employment identification card as proof of employment if applicable. These methods enforce identity management procedures within the healthcare organization and compel the patient prove that he is who he says he is. Because of the HIPAA, patients have the right to refuse to participate in the HIE and to limit who can view their information. A component of identity management within HIE is consent management. Consent management has nothing to do with the consent for treatment, but rather the patient consents or approves the HIO to transmit health information between two or more authorized entities. According to the ONC, electronic consent management is a system, process, or set of policies that enables patients to choose what health information they are willing to permit their healthcare providers to access and share. Consent management allows patients to affirm their participation in electronic health initiatives such as patient portals, personal health records, and health information exchange. And then you see figure 11.5 here that shows the key components for implementation of electronic consent management process. So the first one is patient education and engagement, including educating patients about their consent options, who may release their information and how, and the significance of the consent choice. Number 2 is technology. Using technology to capture and maintain patient consent decisions, identify which sensitive portions of patient information are restricted from access, and communicate these restrictions electronically with others. And last, law and policy. Ensuring alignment with federal and state law and other legal and policy requirements pertaining to consent, individual choice, and confidentiality. Moving over to 197. The process of obtaining approval or consent to transmit health information has 2 components. The first is to obtain consent from the authorized healthcare organization or provider to electronically request or transmit any patient's health information to or from other authorized healthcare entities. This part of the consent process involves the patient consenting to have the health information accessed and released. This is typically done the first time a patient is registered to receive healthcare services at a particular healthcare organization, and then confirmed during any subsequent encounters or admissions. This may be a complete consent allowing all information can be accessed by authorized users. There can also be constraints on the type of access data and by whom it may be released or accessed. All right, so then we go down into the text talking about the opt-in or opt-out consent sets. So it sets the default for health information of patients to be included in the HIO automatically. So that's your opt-in. If you opt in, you're allowing information to be included automatically. The patient cannot or can choose not to be included. So this is their opt-out. And you're allowing the information to be entered into the HIO, and out means you don't want it there at all. Opt-in consent means that the patient must specifically agree to have personal health information accessible in the HIE. And you have variations of consent. You can opt in with restrictions. The default is no patient health information is automatically made available, and the patient must define what information is to be sent, who it is to be sent to, and for what purposes the information may be used. On the opt-out side, with exceptions, It sets the default for health information for patients to be included, but the patient can opt out completely or only select data to be included. And then we have the recommended specific data elements to help with patient identification issues. So you see in the slide 60, the primary data elements are the patient's legal name, first, middle, last, and maiden, their date of birth, their gender, race, mother's maiden name, and their primary phone number. Secondary data elements include their birthplace, marital status, social security number, driver's license number, email address, and some type of biometric. And we know that a biometric is a physical characteristic of the patient or users, such as fingerprints, voice prints, retinal scans, or iris traits, that systems store and use to authenticate identity of the patient or before allowing the user to access a system. And now we get down to our HIE privacy concerns. All health information is private, but mental health diagnosis, drug and alcohol treatment, and sexually transmitted disease identification are considered to be particularly sensitive. The healthcare organization must determine what additional privacy and security protections are in place because some HIEs may not be able to adequately protect that sensitive information. Our best practices addressing privacy issues with HIE include workforce education programs are robust and timely, including the right of the patient to request restrictions. All employees involved in any patient data or information transaction, access to ePHI, PHI, or HIE operations must receive regular and documented training regarding HIPAA and HCO rules, regulations, policies, and procedures. Second, up-to-date breach notifications, policies, and procedures for all HIPAA-covered entities. A recent news of data breaches and identity theft events have shown the public's trust has decreased regarding the ability of an organization to safeguard their information. Third, all mobile devices have effective and strong encryption protection. Number 4, application of breach sanctions are as written in policy and procedures. Depending on the level of breach, sanctions must have commensurate severity of consequences and be established prior to the event following HIPAA guidelines. Number 5, business associate agreements are analyzed, evaluated, and updated on a regular basis. The rules are continually expanded and updated, and the healthcare organization must make certain it follows suit. And sixth, current risk analysis is implemented and revised on a regular basis. Follow-up with business associates, covered entities, and any others must be verified by the healthcare organization to be in compliance. And lastly, over on page 198, requests for restrictions on release of information by patients is implemented and on the Notice of Privacy Practices. The enhanced privacy rule requires the healthcare organization to have a method to note that the information has been restricted. All right, so that ends chapter 11. Again, just be sure to read the whole chapter and, know your terms, know your definitions. There probably is going to be some matching on this test, matching as far as your different types of interoperability, probably going to do some matching on your methods and models of health information exchange. So know those. Again, make sure that you study those review questions for test as well. So happy reading and happy studying.